Honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Rishikesh, feel privileged to welcome you all on behalf of the entire team at Emcure. We at Emcure are proud to present No Thrombosis Live Inbox, our highly acknowledged scientific program dedicated to exploring the multifaceted landscape of interventional cardiology. This program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools needed to enhance the lives of those affected with the cardiac diseases. I take this opportunity to extend a warm welcome to our respected course director, Dr. M.S. Hiremat sir. Sir is director at Cath Lab Ruby Hall, Pune, President CSI 2017, Program Chair CSI Conference 2016. He is convener of National Interventional Council of India in 2004 to 2006 for CSI. He has proctored many interventional cardiologists and has given live courses across the globe. He has great experience in peripheral angioplasty, including legs, iliac, and carotids. He has participated in some groundbreaking clinical trials. So Dr. Hiremat sir is right now busy with some emergency case. Hence, he will join in later part of today's program. Our distinguished moderators, Dr. Arup Das Bishwas sir and Dr. Vikas Thakran sir, are poised to share their knowledge, insights, and practical wisdom to empower us in the fight against the global health challenge of cardiac diseases. It is an honor for me to introduce our distinguished moderators for today. Dr. Arup Das Bishwas sir. Sir is consultant interventional cardiologist at many reputed institutes in Kolkata, director of cardiology at BMRC. Sir is ex-director, HOD, and professor of cardiology in ICVS.
If you may not need to read the whole thing, you can minimize it.
Okay, I'll be crisp, sir. IPG, MER, and Kolkata. He is ex-teacher for DNB, DM exams. Sir is ex-vice president CSI and West Bengal CSI chapter. He is ex-president of West Bengal Academy of Echocardiography. He is ex-member of Ethical Committee, MCI, Board of Studies in Cardiology. He is faculty at many workshops and conferences. Sir has organized many public forum meetings. Sir has conducted many clinical trials, registries, and he has many publications in national and international journals. He is also an assessor of abstract papers submitted for ESC conferences. Warm welcome to you. Thank you, sir, for joining. Let me have privilege to introduce our moderator, Dr. Vikas Thakran sir. Sir is senior consultant and unit head of interventional cardiology at BLK Max Heart Center, Delhi. He is ex-interventional cardiologist at Kalara Hospital, Kirti Nagar, and a part-time super specialist in ESIC Hospital, Basai, Durapur, New Delhi. Sir is research coordinator and cooperator. His first successful leadless pacemaker implant, that is MICRA trial. Sir was also involved in renal denervation for hypertension, Simplicity Hypertension trial in 2014. Thank you, sir, for joining today's program. I would also like to introduce and extend a warm welcome to our speakers for today. We have Dr. Sumit Sethi, sir. Sir is Director of Interventional Cardiology at Max Super Speciality Hospital, Saket, New Delhi. And the case which sir is presenting today is IPST, a nightmare in the cath lab of a different kind. We have another speaker for today, Dr. Rahul Karimungi, sir. Sir is Consultant Interventional Cardiologist at Ashwini Rural Hospital, Kumbari, Solapur. And the case sir is going to present is post-CABG early graft failure, PTCA or redo. Thank you, sir, for accepting our invitation to present the case. And finally, I would also like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me brief you all on the meeting agenda for today. We'll kickstart the program with the opening remarks and context setting from our respected moderator, Dr. Arup Das Bishwas, sir. The meeting will proceed further with the first case presentation by Dr. Sumit Sethi, sir. And there will be a discussion on the case by all the faculty members. Then the second case will be presented by Dr. Rahul Karimungi, sir, and it will be followed by discussion amongst the faculty members. Post the discussion of second case, we'll have the concluding remarks by our esteemed moderators. I request audience to post their questions in the comment box so that we can take up those questions in the end. So without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of interventional cardiology. I request our respected moderator, Dr. Arup Das Bishwas, sir, to share his opening remarks for today's program. Over to you, sir.
Thank you, Dr. Shoaib, for the kind introduction and setting the context of the program also that how you have said it. And I also thank Emcure Group, including you, for organizing this kind of meeting. And this is a very special kind of crucible of knowledge sharing among the interventionalists and other people. And no thrombosis is the established event by this time. And in this knowledge crucible, both the senior interventional cardiologists and the junior ones who are budding have the scope to mingle and interact. So with these words, I would like to invite our first speaker, who is going to speak on nightmare case, Dr. Sumit Sethi, please. He has been already introduced to the audience, but he is a very good interventional cardiologist, and he will be sharing with us the nightmare and how he came out of this. Dr. Shetty, please.
Thank you, Dr. Dasvishwas. I hope, are you able to hear me, everyone?
Yes, we can hear you and see your slides very clearly.
Wonderful.
Yes, you can make it full screen, sir.
Yeah, I'm trying to do that, but it's taking a while. Sometimes technical glitches. Okay. So thank you very much to Emcure Group, Dr. Rishikesh, for this invitation. This is a case which I want to share, which was a very, very tough case. Unfortunately, the outcome was not that great, but let's just go ahead and discuss this case. Okay, so this is a case of what we known as IPST, or intraprocedural stent thrombosis. The gentleman is a 53-year-old male. He had no diabetes or CAD in past. He was a hypertensive, non-smoker. He had a history of varicose vein surgery 20 years back, and he presented to our emergency at 2 a.m. in the morning with typical chest pain, off and on, of 10 hours duration. This was the first ECG. You can see in the V2 and V3, there is some early uptake of ST. Otherwise, no major changes. So when the emergency medical officer saw this case, they thought that, this is acute coronary syndrome. With their own wisdom, they loaded the patient with Disprin, clopidogrel, atorvastatin, and they informed the cardiology on call to see. So the cardiology call was on his way, and before he could reach the emergency, around 10-15 minutes later, patient had a cardiac arrest in the triage. Pulses were not palpable. Monitor showed a ventricular fibrillation. He was defibrillated with the DC shock. A bag and mask ventilation was given, and patient had 3 minutes of high quality CPR. A ROSC was achieved. Blood pressure was 90/60. Noradrenaline was started in the emergency, and an ECG was repeated, which you can see now shows frank hyperacute anterior wall ST elevation wall MI. So with this kind of an ECG, the patient was shifted to the cath lab for an emergency primary angioplasty. In the cath lab, he was given, loading with the ticagrelor 180 milligram. Can you see the slides? Just want a confirmation.
Yes, sir.
Yes, we can see the slides.
Okay. So this is the first shot. We took a groin shot. This is, as you can see, a very clean puncture. This image is going to be of context later on when we approach the case, but this is the first shot. So the right coronary artery was unremarkable. As you can see, there's nothing there. It's clean artery. The circumflex, the OM branch was a very huge branch. And as you can see, there is a moderate size diagonal. And just beyond that diagonal, there is a complete cutoff of the LAD. The lesion was crossed with the BMW wire. It went easily. And we also thought the diagonal was a moderate size vessel. Let's protect it with another BMW wire, which was crossed diligently. The patient had ongoing chest pain. He was in distress. So immediately a balloon was taken to get some flow into the arteries. This is a 2 millimeter balloon, just gentle dilatation, 6 to 8 millimeters. And you can see that we have achieved almost like a TIMI 3 flow. Not much of a thrombus load here. As you can see, the diagonal is still flowing. So in light of this, it was thought that we should just pre-dilate the patient a little more. There appears to be a mild calcium there. So a 2.25 millimeter balloon was taken to further pre-dilate the lesion before a stent was chosen. We didn't do any thrombosuction because the flow after a gentle balloon was very good. So balloon export thrombosuction was deferred. So this is after the 2 millimeter balloon. There was some slow flow, or rather, no flow in the diagonal. So the diagonal was also pre-dilated to get the flow back into the diagonal. And now you see that, with this post-dilatation, there is some appearance of thrombus, which was not seen earlier. I will come to the heparin dosages and whatever antiplatelets we used later on as we progress, but suffice to say that enough, heparin was given at the start, and the ACT was about 220, 230, 240 at this stage. More further heparin was given, and a stent. This is a 3 mm stent, which was deployed in LAD. So as we can see, a fairly good result appears to be okay, and this was further post-dilated with a 3 mm NC balloon at about 14 to 16 atmospheres, and this is the check shot after this thing. A fairly sort of a okay result. The diagonal is gone here, or rather a very poor flow. So again, it was thought that we will wire the diagonal again, but the post-stenting the wiring was difficult, so it was left at this stage. However, after about 2 minutes, when we took a check shot, you can see that there is fresh appearance of a thrombus in this artery, which was quite surprising because we had given enough heparin. But one thing which was happening in this patient was that the ACT was not rising enough. So seeing this kind of a horrible thrombus, it was decided that we'll use a bailout, abciximab, which was given at the dosages as per the patient's body weight. And we waited for some more time. We, did some more post-dilatation in the hope of settling the thrombus back into, or rather, behind the stent struts. And the check shot was repeated. There was some, improvement in the overall picture, but you can still see that the entire stent is still studded with the thrombus and the diagonal is gone completely. Again, waited for 5 minutes. Despite the abciximab, now you can see again there is some appearance of thrombus, despite quite a bit of heparin and this thing. Anyway, we waited for 5 minutes, took out the catheter, and just waited on the table for 5 minutes to see if things would improve. After 5 minutes, when we took the check shot again, you can see again there is a fresh appearance of thrombus. So this kept on increasing, without any intervention. Another shot after 2 minutes shows that the thrombus is back again. At this time, we didn't really know what to do. So we thought that, let's just rule out any mechanical cause, and we did an IVUS in this case. So this is the IVUS run. I'll just go through it quickly because we have limited time. And as you can see that, at this stage, at the distal stent, you can see this thrombus from 9 o'clock to 12 o'clock. And as we go forward, the stent appears to be fairly undersized for the vessel. This is the stent, as you can see, and the vessel is a large stent, and it appears to be a sort of an undersized stent. So keeping this, IVUS picture in mind, we took, as you can see, that the stent size is about 2.75 deployed stent, and actually the vessel size is 3.75. So we had some work to do in this kind of a situation. We took a 3.5 mm balloon now in a 3 mm stent and dilated to quite high pressure, 16 to 18 atmospheres. So this is the post balloon optimization. Again, I'll just go through, but this time you can see that the stent has definitely improved in size. There is much more apposition as compared to what we had initially. There is still some thrombus behind the stent struts here, but overall the stent apposition was much better than before using a 3.5 mm balloon. So this is the sort of final check shot. You can see the artery is definitely looking much better. The stented segment thrombus is less, and anyway we had given quite a bit of, as you can see, the total heparin which was given repeatedly was about 17,000 units. The ACT was not rising enough initially. We checked it from our different ACT machine, from the OT as well, and despite 15, 16, this thing after about 1.5 hours of angioplasty, only in the end we could get a heparin, the ACT of about 340, 344. We had almost used 15 milligram of abciximab during the stages of the case. Brilinta, as you already know, was loaded in the beginning. And in fact, when the thrombus were coming again and again, we thought that this is probably some sort of a heparin resistance, and even an injection Clexane or low molecular weight heparin were also given. So as per the chart, the patient was 72 kilograms. We desired a bolus of abciximab of 18. We didn't cross that. We gave him 15 milligram only. So total heparin 17,000 units, abciximab 15 milligram, low molecular weight heparin ticagrelor. This is the anti-platelet and anti-coagulant cocktail that the patient had. He was shifted back to our ICU. We did a quick echo which showed ejection fraction 35%. But interestingly, there was appearance of an apical clot in the echo. As you can see, that there is some sort of an apical clot. So it became more and more apparent that maybe the patient has some sort of procoagulant disorder, because you don't get a LV clot occurring so early and with the thrombus despite so much of antiplatelets occurring again and again. Anyway, the patient was shifted and you can see the ST has settled down nicely. But 2 hours later, patient had shortness of breath, tachycardia, hypotension, and they showed re-elevation of ST. So we thought this is a clear-cut case of stent thrombosis. We took him back to the cath lab, took a chunk angio, but to our surprise, the artery was flowing very well, and even the residual thrombus which was there in the stent had actually kind of melted off. So the patient was shifted back to our ICU. He had unstable, rather in the cath lab, he had unstable hemodynamics. The second time when the check angio was done, he had pulmonary edema. He was electively intubated in the cath lab. IABP was inserted through the right groin, and he was shifted back to our ICU. What then came across in the next couple of hours was that we had started with a hemoglobin of 12.8. Gradually, patient fell from 12.8 to 10.7, and within 2 hours, his hemoglobin was 6. So clearly, he was bleeding somewhere. The other labs were creatinine 1.4, LFT normal, PTINR surprisingly 2.29. So clinically, when we looked at the site of bleeding, there was no groin hematoma. As you had seen the puncture in the initial stages, it was a clean puncture. There was no bleeding in Ryl's tube, so no upper GI bleed. There was no blood on PR examination. The surgeon was called and the abdomen was soft. Yes, sir.
Can you hold for a minute here and ask the audience whether they have any suggestion regarding the hematological changes and the falling condition, whether they can suggest anything at this level? They can respond in the chat box, I think. Is there any suggestion from the audience that this could be the reason and this has to be done? Because after doing everything, Dr. Shetty and his group is facing the problem. Initially, it was a prothrombotic situation. Now it is a hemorrhagic situation, which may be due to the so much of drugs that was required to dissolve the thrombus, recurrently appearing thrombus in the stent. And at that time, they also checked the cardiac catheter, etc., whether any thrombus was inadvertently coming from that region also. So they have checked that. Now, what does it come to your mind? I'm asking the audience. Then I'll be coming to the interaction specialists, like Karimungi is there.
So I request audience if they want to put their opinion in the chat box.
I think Dr. Shevale, we have got up to 8:30 p.m. for this case.
Yes, sir. Timing 5-10 minutes.
Okay,
back and forth is fine. No issues.
Interrupting here and again come back to Dr. Shetty.
Okay.
Dr. Karimun, any thought process?
Yes, sir. The most likely possibility, what I've seen commonly is development of cardiac tamponade, some pericardial effusion.
Okay, that is one possibility. But I think when he was shifted, they must have done an echo.
Yes.
Yeah, the echo showed no pericardial effusion. There was LV clot appearance, but otherwise no pericardial effusion.
I got muted. So they must have excluded that at the outset because of the worsening condition of the patient. So cardiac tamponade, yes, that has to be remembered by the juniors always. Anything else? I think retroperitoneal hematoma is also a possibility because there was a femoral approach, and he has done everything to exclude blood from other places. That is a probability. Now let's hear again from Dr. Shetty.
Right. So clinically at this time, the abdomen was soft and we really didn't know anything. The surgeon was on hand and, he suggested that we do a blind. Okay, so before that, we did ultrasound as well to see what was happening. There was suggestion of some moderate ascites with echoes within it. And interestingly, they also said that there was altered liver echo texture and there was the portal vein was thinned out with diminished flow. Again, suggestive of some portal vein thrombosis. Now he had, a stent thrombosis, intraprocedural stent thrombosis. There is suggestion of portal vein thrombosis. There was appearance of an LV clot. So clearly, maybe some sort of a procoagulant disorder which the patient was having. Anyway, with this kind of a situation, when there is moderate ascites as well with echoes in it, you have to rule out any blood in the abdomen. A blind puncture was done from the abdomen, as you can see that we aspirated blood. So most likely he was bleeding, as Dr. Dashwispa suggested, that it could have been a retroperitoneal hematoma as well. He had had a cocktail of so many antiplatelets, which we had to give because Otherwise, we probably would have lost the patient in the first time only when the thrombus was coming back again and again and again. So he continued to be sick, and eventually we could not save this patient. Now, just a couple of slides. This is the final diagnosis: hypertension, STEMI, anterior severe LV dysfunction, primary VF, post CPR status, IPST, probably heparin resistance, probably some coagulopathy, hemoperitoneum, cardiogenic oblique hypovolemic shock. So I just did some research on this, that what is the impact of intraprocedural stent thrombosis on outcomes of PCI meta-analysis. So it is a rare phenomena. It is not very common. IPST is 0.8, less than 1%. So even though it is rare, it is associated with more adverse ischemic events, including higher mortality at 30 days and 1 year. Another study, this is from Validate Sweetheart sub-study in patients who had IPST treated with potent P2 white coil inhibitors, something like our patient who had ticagrelor. Again, I would just like you to concentrate on the yellow lines, that it is defined as a new or worsening thrombus related to stent deployment during the procedure, again 0.9%, more significantly associated with ST segment elevation, longer stents, bailout glycoprotein GP2B3 haters, and final TIMI flow of less than 3. So patients who have IPST have significantly higher rates of primary composite endpoints, 20% versus 4.4%, which includes higher rates of cardiovascular death, target vessel revascularization, definite stent thrombosis, but not major bleeding. So again, if you see this, this is the 30-day outcome, and this is the 6-month outcome. The red line is the IPST patients. They fare far worse than the patient who has no intraprocedural stent thrombosis. So once this occurs in the cath lab, you have to be very, very careful. That's why these patients will have a very bad prognosis. Although rare, IPST should be recognized as an important and dangerous event during PCI, even in the contemporary area of potent antithrombotics. Why IPST is associated with the higher risk of adverse outcome despite the immediate detection and possibility of treatment is not known, and the factors which we have all discussed, longer stent, STEMI, and final flow, which is low. Now, there is no difference whether you use bivalirudin or heparin during the procedure. What happens is that as you keep on giving additional heparin because of low ACT in patients with IPST, low activated clotting times during PCI could represent a risk marker of IPST. This patient had very difficulty in getting his ACT up. That's why you have to keep on giving repeated heparin. Bailout GPI is another possible treatment strategy frequently used, although without clinical benefit in this opposition study. So even a bailout GPI may or may not help. This is a diffuse thrombus which is occurring. It's not like a chunk of thrombus. This is something as if the whole artery is reacting towards the foreign body with a prothrombotic state. Of note, there was no increase in bleeding rates among patients with IPST versus without IPST, despite the more frequent use of additive antithrombotic medications. So ultimately, we don't know what is the ideal treatment strategy during PCI. We have to balance the risk of thrombosis, which is occurring in front of your own eyes, and the bleeding complications. And you need, I don't think any such study can be done because these patients are going to be so rare. It's using your own clinical judgment at that time, which is probably going to, either sink your patient or save your patient. Also, one of the things that administration of unfractionated heparin can also activate platelets and release platelet factor 4, a known heparin binding protein. So you are giving more heparin, but at the same time, you're probably activating your platelets more. So very tough situation. This is my last slide. The points for discussion. What does the audience think and the moderators and the chairperson think? Did we over anticoagulate our patient? If yes, then how else to manage IPST when ACT is not rising, commensurate with the heparin dose and fresh instant thrombosis seen? And do we need imaging upfront, even in STEMI, to reduce stent size mismatch, which could have been a factor in this case? Did that contribute to IPST, or was it only mainly pharmacological with the patient having some underlying coagulopathy? We didn't have enough time to actually study the various coagulant factors in this patient. He was, he survived only for about 10, 12 hours. Thank you very much for your kind attention.
Thank you, Dr. Shetty. Did you do any, after the events were over, any hematological test to know whether he was suffering from any prothrombotic situation?
We didn't have time. He passed within 2 hours of coming out of the cath lab.
So, did you take any hematologist opinion or do such tests?
Hematologist was called. They had asked for various tests to be done, like protein C, protein S, lupus anticoagulant. And by the time we organized the patient, the second episode when he was intubated in the cath lab, when he had IBP, and then he continued to bleed. So he was so unstable that people were trying to manage him, get out of this
Go back to
crisis.
the audience as well as Dr. Karimungi to interact with particularly with reference to the questions Dr. Shetty has posed. And thank you, Dr. Shetty, for presenting this case. A very important one, though rarity of this kind, but illuminating one. Dr. Karimungi, any
Yes,
thought process?
excellent case, sir. First, I think it is more of a pharmacological rather than the stent size, because so much of thrombosis development just because of some stent mismatch is not that much possible. So it's more likely of a pharmacological as well as some congenital abnormalities, as you said. Some deficiencies or some mutational deficiency, protein C, protein S may be possible.
And
And
regarding
patient
the
has
third
underlying
question, yeah, please continue. Sorry to interrupt. Yes, please tell.
only has portal vein thrombosis, as sir said. So it's more likely that this could be due to protein C as deficiency. Whether it was a spontaneous, as per the history, it was a spontaneous portal vein thrombosis. And patient was non-alcoholic, non-smoker. So all this, considering the risk factors, so I think it is more of a thrombotic step rather than the stent mismatch.
So one is prothrombotic state, yes. Another, whether it would be heparin-induced problem. A lot of heparin was given. So that leads to thrombocytopenia and other problems. Do you think
Yeah,
that?
so this was more like a heparin resistance, and which we had to overcome by using bailout GPI. And also, it has been known that when your heparin doesn't work unfractionated, you can try bivalirudin oblique. Low molecular weight heparin has been used in the cath lab. We did all that. Bivalirudin, of course, we didn't have, but it's a two-edged sword. At one time, you're giving antiplatelet and everything to try and maintain your acute result good, that at least the patient does not have thrombosis. But at the same time, you're also buying a risk of bleeding, and especially if the patient has some underlying coagulopathy, then both situations, whether it's thrombosis or whether it's bleeding, is going to be more common in this kind of.
And regarding the imaging, I think that when we are in emergency situation like this condition, he had just brought resuscitated and then brought to the cath lab. So people were in a hurry to reperfuse rather than thinking anything else. And usually we go in by without doing any imaging straightway, remove the thrombus or just dilate it with the stent. At times even do not pre-dilate, go for a direct stenting, etc. to minimize the time. That is the main thing. But once you are in trouble, this shows that the importance of IVUS is very much so that you can detect the underdilatation and apposition could be made subsequently. So that was the right thing to do, I think. Dr. Karimundi, do you think that you will be going for imaging first and then stent in a case of STEMI like this?
No, sir. Directly, I will go for stenting instead of
Yes, so time is the main issue there. We don't usually undertake imaging. So, but when you are in trouble, this has to be, so it is better to have on board. There are many places in India in the cath lab who doesn't have these facilities. They only bring the Boston people or Philips people to do this kind of imaging but that has to be pre-arranged. They cannot do online whenever needed. So it is better to have this kind of accessories. These are no longer accessories. They are now almost a necessity to have them. Any more
Excuse me, sir.
Sir,
Yes.
this is Dr. Vikas sir is giving his
Yes,
comments. He is
Dr.
moderator.
Please.
Sir, Dr. Sethi, this
Yeah,
is
because
just, in the end, did we check, had a final check shot also in the end for the femorals? Actually, you did it in the beginning. Any final check shot before shifting the patient?
no, that was not done because clinically there was no hematoma,
No issues.
and the first puncture was very, very clean.
No, the puncture was absolutely clean. Actually, if I take it from the beginning, we had initially a problem of thrombosis, and later on check shot, our stent was patent. So what? And let me just have some experiences based on this. Maybe initially, so what was the total procedure time? Maybe initially the stenting and all.
About 1.5 hours.
1.5 hours. So maybe sometimes were they all the Oxford and New York? Sometimes we have these Oxford balloons and which are usually not very well prepared. And these,
Okay, because let me just tell you here only that in a STEMI we don't use Oxford.
so that part is again out.
Yeah, we don't
Then
use it
if I
in our
go
lab.
with the one thing that the patient had portal vein thrombosis. So if we talk about a patient who is non-alcoholic and cirrhotic, they have antithrombin 3 deficiency, which is a major factor which you would require for heparin to act. And also, once we have given more of heparin, Clexane, because these hematomas also consume heparin. So when the patient was shifted, sometimes the groin is, the patient folds the legs, and we know about, them bleeding later on. We had a definite bleed. So this patient might be having some underlying liver disease, as per me, which required a lot of heparin because of the inherent antithrombin 3 deficiency. And ultimately, the stent was patent in the end. So maybe the large doses was able to get the desired ACT, and at the desired ACT, you had a patent stent. So maybe later on, maybe this was some mechanical shifting problem, or maybe the hematoma was the ultimate thing, but he definitely required higher level of heparin. So if you have heparin more than 35,000 requirement in a 24 hours, we will call it as true resistance. Or sometimes we do not reach the ACT level, it is pseudo resistance. So this patient, given the scenario of portal vein thrombosis and maybe echo texture slightly altered, must have been either a non-NASH related CLD or some other thing. So that is what my take is.
Thank you, Dr. Thakran, for your wise comments. Now, I think, is there any question in the chat box, Dr.
So, Ankit, is there any question from audience in the chat box before we go for the next case?
So one question I have.
Okay.
So if the stent is patent, why the changes were seen in the ECG? Why did they felt like the stent thrombosis?
Is there Dr. Shetty there?
I think he's left out.
Can he hear or net has gone?
I think he has left. He was having some case. So
Okay.
he might have. So any of the moderators can take up the question, like if Dr.
Dr.
At times
Vikas
we
or
have
Dr.
seen
Arup.
Respond, please.
the ST changes sometimes take, times to settle even after proper revascularization. This is often seen phenomena. The point was, if there is re-ST elevation, so if the ST was initially settled and later on it re-elevated, that would have been more important. And because the patient had bled, gone into hypertension, so maybe the initial infarct related area must have shown these repolarization changes in view of hypotension.
Yeah, during the discussion, sir said that there was re-elevation of the ST segment, because
So maybe ST
Infarct zone
settled
has
was
extended. Actually, infarct zone has extended, as Dr.
maybe
Thakran
most likely.
yes, sir.
Most
pointing
likely.
out. In fact, actually, if you remember, you do of course remember, I'm talking to the juniors. Whenever an infarct is in the developing process, you have got multiple zones, zone of true infarct and stunned zone, and subsequently those zones will be in future hibernate. Now, as the assault goes on, the infarct zone expands quickly, not in the chronic situation, but in the acute situation. So that must have been the case here. So may we move to the next case?
Sure, sir.
Yes. So Dr. Karimuli, your case is the next case, I think.
Yes, sir.
And this is a post-CABG early graft failure, PTCA or redo, what to be done. So would you be discussing based upon a case?
Yeah, it's a case discussion.
Okay, thank you so much.
More of like a confusion instead of discussion, like what should be done for this patient.
Yes, please go ahead.
Just sharing the slides. Is that visible to everyone?
Yes, sir, we can see. Yes, sir.
So we'll directly go for the case. So this is a post CBG patient and he had early graft failure. So the confusion was regarding whether to go for redo CABG or for the PTCA. So diabetic since last 10 years on regular anti-diabetic medications. He presented to a nearby private hospital, which was near his home, with chest pain at rest and dyspnea for last 12 hours. And past history, he had underwent CABG 4 months prior of this event at the tertiary care center at our institute, and he was on regular dual antiplatelet medications as well as anti nicorandil and all those medications. So on clinical examination, pulse rate was 108 per minute, tachycardia was there, blood pressure was borderline high, and fine basal crepitations on auscultation as per the records of that hospital. So immediate ECG showed minimal 0.5 millimeter horizontal ST depressions. You can see here only in V5, V6. That is not very significant. Rest of the ECG is not that has any ST segment elevation. 2D-co revealed moderate LV dysfunction with EF of 40%. All iliapical segments were kinetic with preserved thickness. So this is what was the reports available with us. And cardiac biomarkers property was borderline positive, and they planned for coronary angiogram.
So going to coronary angiography, what was your clinical diagnosis?
So it
What
was
is
non-ST elevation MI, sir.
So NSTEMI was your prognosis.
NSTEMI was the diagnosis. And this angiogram was done at the other institute, other private hospital, not at our institute. And it revealed native triple cell disease with 70% left main disease, 99% subtotal occlusion in mid LAD, 90% stenosis in ostial 6, and graft angio critical narrowing of Lima LED graft as well as SVG PDA graft. I will share the images. So this was what was seen in on angiogram. So it has a typical left main disease with critical ostial L6 narrowing and distal almost 99% to subtotal or total occlusion of mid LED with some amount of competitive flow. And this was the RCA flow, which has mid 100% total CTO occlusion. And graft angio showed Lima to LED at the site of anstenosis, almost critical narrowing. You can see here. And the SVG graft also has critical narrowing at the anesthetic site with TIMI 2 to 3 flow distally. So this patient came with angiogram and he was referred for redo CABG at our institute. And after consulting with CVT surgeon, he asked me the possibility of angioplasty in this patient because only recently CABG was done 4 months back. So, and the age of the patient is only 47 years. So, considering the very high risk for redo CABG, multi-vessel PTCA was planned. So, started on nicorandil infusion, unfractionated heparin 8000 units was given with ACT of 340 and 6-bench EB catheter and field Rep-C wire used. And particularly this patient underwent CABG in local Maharashtra government scheme. Again, angioplasty was done in the same scheme. So there is some restrictions as like a low resource setting kind of LED was crossed with field Rep-C wire. And initially 1.5 balloon, non-AC balloon was used to dilate the mid to distal LED. And you can see artery opened up. Followed by 2.0 balloon, non-AC balloon was used to further dilate the artery. And later on dilated, stented with 2.5 48 millimeter proficient stent covering the graft anesthetic site. And TIMI 3 flow was achieved post dilated with NC 2.5 NC balloon. The problem lies now is left main and L6 ostium. So what to be done for this patient? So L6 was wired and 2.5 pre-dilated with 1.5 balloon, and planned for stenting with 2.5 19 millimeter proficient stent from the ostium. And it was dilated, and the good symmetry flow was achieved distally. And again, post-dilated is 2.5 NC balloon. Later on, again LED was recrossed with filter FC wire and stent pre-dilated with 2.5 balloon, and stenting was done with 3.5 19 millimeter proficient stent, and post-dilated 3.5 8 millimeter NC balloon. So this was the end result. And distal LED has some amount of lesions, but with good flow. Both LCX as well as LED has TV3 flow. So post-procedure patient was shifted to ICU and was hemodynamically stable. On post-op day 3, patient was discharged with medications as aspirin, ticagrelor, atorvastatin 80 mg, metoprolol XL 50, Remipil 2.5, and as well as continued his antidiabetic medications. So he came for first follow-up after 10 days. 2 days back, his renal function test was normal, and he was completely asymptomatic, and medications was reviewed. So the questions now is, what other thing can be done in this case, in such situation in low resource settings, and how to treat RCA lesion, because that was left untreated because already 3 stents were used as restrictions were there in government schemes. Maximum of 3 stents, only 3 stents we can use. So I thought if patient is symptomatic later on, then RCA can be tackled. And problem is how it should be done. What is the optimal management strategy in such patients, and in such low resource settings, what can be done differently?
Thank you, Dr. Karimani, for presenting. This is a real life situation case. We get these type of cases when, particularly in the diabetic, very often.
Yes, sir.
So I think, can you go back to your question slide?
Yes, sir.
So in this context, may I invite Dr. Thakran past this time to answer not only these questions, but also ponder his reflections on the intervention itself. And the title of the case is PTCA or redo. So I think you can take up that issue first, whether you would go for PTCA or redo CABG in such a case.
So basically, if we look at the anatomy initially also, we could have attempted both the things, because the left main LED, now it is all jailed, all metal jacket. So I would just like to go back to the slides, please, that what was the strategy used for the left main bifurcation?
So I didn't use 2-wire strategy.
We had this. So what was our plan in the left main bifurcation here?
And
So
for that
basically-
understanding, I think, Dr. Thakaran, what is very important to assess the Lima graft. If the Lima graft is working well, yes, that may take care. But whether circumflex or obtuse marginals were revascularized from beforehand, I don't know. So that becomes a real problem. As you have talked about the jailing the lesions. So,
The
Dr.
point is,
Karimani, what is the opinion of your cardiac surgeons? Number one, what was the status of the graft? And number two, why the graft failed so early? Maybe he's diabetic, but why? Because there are certain technical issues while doing a surgery, and some grafts fail earlier, some grafts stay for longer. Well, was there any decision from their side, from the surgical side? Then I'll come back to Dr. Thakran again for his comments.
So as we discussed with CVT surgeon, so I'm most likely it is a technical issue other than some thrombotic state. So actually, even he don't identify what is the real cause for this early stenosis or critical narrowing of Lima graft as well as SVG to RCA graft. So the strategy I used here particularly is first looking at the LCX, at the angulation of LCX, I thought it's not possible to stent the LCX at all. because the left main as well as the ostial LAD both are diseased, and without using two stent strategy, it's very difficult to do LCX alone and leaving left main without treating.
What was the
Dr.
strategy?
Thakur, please.
Name of this strategy, maybe in this scenario?
So I
Did we
thought
recross and do any kissing balloon or open the strut
kissing,
of the circumflex?
kissing balloon I couldn't try because using ox balloon is not possible to cross these kind of stent studs. So kissing balloon was not done at all. That's why I thought it should have been done in this case. That was a must. But looking at the things, so
Okay, so maybe this is
what you
the resource limited setting was the issue.
yes,
So the
sir.
point is keep the patient, if in both the scenarios, antegrade approach here was the better than going to the tortuous lemma, especially with the wiring of that lemma. It sometimes leads to the concertina effect. So the patient gets in trouble. So
Yes,
this was the right approach, but I would have been, much happier if if this was a mini crush technique when both the stents are taken together and then we do a final kissing. So what's done is done. Now the part is about the RCA again would require maybe backup of microcatheters and CTOs and wires. So maybe you can just counsel the patient to have some expenses on his side, because it cannot be totally free from, patient cannot expect everything for free.
yeah,
Or he may go to a center where those are government backed centers in which maybe this RCCT opening can be attempted.
sure. Yes.
Dr. Shetty, your opinion on this case? Have you seen that? Were you present during the discussion? Yeah, please unmute yourself.
Yeah, Dr. Dasvishwas, I saw the case. I'm unfortunately losing my network from time to time, but I saw the case and I heard everyone's comments. So I think I agree with most of the things which have been said. Of course, one of the main things which has been missed is kissing, especially in a left main setting when you have done so much of hard work for that native LAD to open it up. Long stent in mid to proximal LAD and then did a two-stent strategy. Which way or the other, sometimes we can ask the companies to provide us a free balloon or something like that. But you should, I mean, for a left main two stent, we have to end with a kissing. Otherwise, we may land up with, a very early ISR, especially at the subcostium. And, or, if the patient is really unfortunate to stent thrombosis. That's one. I agree that this should not have been sent for a D2 CABG. You have to do PCR for this kind of an early graft failure. And now the third question, how to do that RCA? If I see besides the anastomotic point, there was degenerative disease in the RCA main
Yes,
graft body as well. So that's a
mid.
long lesion. We're probably looking at two stent there as well. Yes, if the CTO is openable, we should do a CTO. And sometimes, these patients can be just left on medical management. He's asymptomatic. Maybe you give him some time and then assess, maybe with a stress thallium in 4 to 6 weeks. And he could just be doing pretty well, especially since you have used so much of resources. However, if the patient becomes symptomatic with chest pain or if the stress thallium is positive for ischemia, then you'll have to again figure out the way to treat it, either to native or maybe two long stints through that SVG to RCA graft.
Okay.
So,
RC again is sir at bifurcation, I think. Distal anastomosis to RC PDA. So again, that will be a trouble to choose the side.
Yeah, it
And
all depends upon how bad the CTO is. Has it been there for 5, 6? He's a diabetic,
yes,
so likely to have a calcified CTO.
and
We didn't see the native angio of the
yes, sir,
RCA
that
per
is the
se,
one
so
issue.
we don't know.
And maybe 4 months if
and
this
my
graft
question,
has degenerated.
sorry, Dr. Thakaran, please continue. Sorry to interrupt.
Sir, this SVG graft has degenerated in 4 months in the mid part. So I'm not really interested in going into that side because, uh, again, maybe these long stents, maybe in the body at the bifurcation, maybe CTO attempt would be a better choice if possible.
Definitely. But also it brings us to the fact that, what was the handling of the graft during surgery? This
Yes,
all
that is
reflects poor handling of the graft when you're taking out the graft,
definitely
when you're putting it. In
anastomosis
four
of the
months, if your graft is looking like as if it was a 10-year-old graft,
10-year
then
old graft.
obviously we have felt short while doing the surgery, and maybe the feedback to the surgeon should also be provided in this kind of situation.
One question to Dr. Karimangre.
Yes, sir.
This was a difficult left main bifurcation. So did you consider of imaging prior to your intervention?
No,
Sir,
sir.
this was such a resource limited setting. I think
Don't
even
have
to
that.
kissing imaging would have been very difficult. But
They
Dr.
have
Rao,
got
please.
resource limitation. Okay. Then it has to be accepted. But the way they have done, that is discussing among themselves between the surgeon and the interventionist, that is the correct approach. And the balance swings. If the surgical team is more expert than the inexperienced, they can go ahead. If the interventionists are very expert and experienced, that goes first. Of course, from the patient's point of view, intervention is more acceptable. And in this diabetic patient, redo surgery may be leading to a problem of sternal wound, etc. Yes, Dr. Sethi.
Just one last comment. So if while doing this left main bifurcation, if you realize that you will not have the hardware or the balloons to do a final kissing, I think we can go in with a one stent strategy, left main to LED, and wait for the circ to present itself after that. If there is pinching, you can still get away with some minor kissing and make just the struts of the circ open. When we land up with the elective two-stent strategy, kissing is a must. So left main to LED, see how the circ behaves. I don't think the circ costume was that bad that it would have led to an acute closure on the table, but this is just a thought.
Actually, the mid-distal LED lesion, that was the culprit lesion at this time, the apical problem. So if somebody finds that I can do just that only at the initial phase, then leave for subsequent stage procedure in a better center. That is also another
Again, very
option.
important. Totally agree, sir, with that.
If it is
Yeah,
junior,
I agree, Dr. Das Vishwas. In this angio, which is being seen, the distal left main and prox LED osteolysis don't look that critical. You're right. Can you just run it, Dr. Rahul?
Yes, sir.
Yeah, it doesn't look that bad. Doesn't look that bad.
So,
Just maybe the mid LED and the first stent would have been enough, but then it's okay.
apparently, 6 osteoma is very critical. So I
Yeah,
thought,
it's a non-dominant circ. It's not a very large circ, but at the same time, your RC is also diseased. You have problem there as well. So yeah, it's a tough situation. You have to go take a call on the table. But if just going by principles, ideally as far as possible, a two-stent left main has to end up with a good kiss and maybe a pot as well.
so is there any question in the chat box?
Ankit, RX event, any question in the chat box? Can you copy paste in this link? I couldn't see it. Is anybody able to see it in the chat box in faculty link?
No, I can't see anything.
Ankit, where
Can
can see
somebody
the-
read out if there is someone posing any question? Because audience is the most important component of this kind of discussion.
Yes, sir. Ankit, please post in this chat box so that we can
You
take up
can't
those
see, but
questions.
some of your colleague was saying that there was a question.
Yeah, but RX event needs to copy paste. Ankit, can you paste here in chat box? Can you see?
There is no chat box, only I can see. Option of a
Yeah,
chat box
Ankit,
also
that's
is
what
not
I am
there.
asking you.
I think you can take up the slides first, then chat box may appear. Dr. Kalibunga, just take up your slides.
yeah, stop.
Stop the share screen.
Yes, sir.
Or maybe you can read it out, RX event.
Okay.
Yes, anyone
so,
can read it out.
So one, I'll just read out few comments. One was like when Dr. Arup Das Vishwas sir asked initially about the first case, like what is your, asked the audience about what is the probable diagnosis. So Dr. Pankaj posted drug-induced hemolysis. Then there was one more comment from Dr. Pranav, retroperitoneal peritoneal bleed. That was the possibility the audience answered to that question.
Okay, thanks for the response of the audience. They have been active so far.
Yeah, and there were one or two more comments. Like I think this is probably for the first case. Like radial PCI is preferred in STEMI. Why not radial approach was taken? That is the question. This is
In the
probably
first
for the
case,
first question.
First case.
I think so.
Yeah,
Yes,
I can answer that. If you realize that the patient had a VF in the triage and he was resuscitated, his pulse was feeble and he had a BP of 90/60 on NORAD. That's why we had to go for a femoral ablation. It was
and
not an easily
another
cath.
comment, Dr. Shetty, I think the operator decides which way to go. It's not that it has to be a rule.
Yeah.
A rule of thumb
There is no
that
rule.
radial,
There is no rule.
radial only.
There is no.
Because
Yeah, for a standard run of the mill, STEMI which you have, patient is stable, some chest pain, borderline hemodynamics are good. Yes, 90% of our cases are radial. But when the patient is this kind of a situation where you anyway might require an IBP, you might require a femoral vein puncture for a TPI, and the radial pulse is feeble. There is no point struggling to get a radial pulse and waste more time. We straight away go for
another
such
thing that
complex
as the
situations.
patient started with an arrest, so maybe that supporting like IBP or any supporting thing would be required at any time. So femoral could be the approach. Yeah. So this is the operator decision. It doesn't have any rule of thumb. But I think these two cases have been a very illuminating one. And thanks Dr. Thakaran, Dr. Sevale, Dr. Karimungi, and the Nucron Marketing Group, Mr. Jai Prakash, to be on board, and particularly the faculty for the very lively discussion. Thanks for presenting the real life situation, the real problems, and a case befitting the title, Know Your Thrombus, that is such a resistant type of thrombus at the same time bleeding. Dr. Shetty's case was a mixed one, and leads to that we know very little till about thrombus. So many cascades, so many in the bleeding cascade, so many things, and particularly thrombotic cascade, so many things, intrinsic, extrinsic, etc. And Dr. Thakran very true, rightly pointed out that the drug-induced problems may be also there. So I think you deserve all a special clap, and I thank the audience particularly for being in the active mode. And I hand over the mic to Rishikesh.
Yes, sir. Thank you, sir.
Yeah, Dr.
Thank you,
Rishikesh,
sir,
before
for
we end,
sharing your.
just tell Dr. Hiramat that we missed him in the meeting, and hopefully he'll be there next time. He would have had
Yes,
a
sir. Actually, I
and,
even
and
again
thank you to Dr.
contacted,
Das
but
Vishwas
sir
for
was
actually
busy with
taking over
farming.
the duty
Yeah.
and moderating the session. Thank you, Dr. Vishwas, sir.
Thank you so much.
Yeah. So I request Dr. Vikas Thakran, sir, to share his remarks also before we close today.
Again, these two cases were, very enlightening, I would say. Maybe sometimes if we have a patient with post CPR acute phase reactants rise, then also, these are the factors which, if we go about the heparin resistance. And in the second case, I would, as Dr. Arup said, that maybe do the only middle part and later on very well planned. I was guided if indicated, then only do the left main. So these are the maybe remarks about the procedures. And it was, I would really thank both the presenters for their wonderful cases.
Thank you, sir. So I would like to express my deepest gratitude to our distinguished moderators, Dr. Arup Das Vishwas, sir, and Dr. Vikas Thakran, sir, for sharing their knowledge and expertise with us today. I would also like to thank Dr. Sumit Sethi, sir, and Dr. Rahul Karimungi, sir, for their insightful case presentations. Your contribution has undoubtedly expanded our understanding pertaining to the cases discussed today. I would also like to thank our esteemed audience for their time, continued love, and support for the No Thrombosis program. On behalf of Emcure, I extend my heartfelt thanks to everyone from sales, marketing, and medical team at Emcure who have contributed to this program's success. Thank you all once again for attending and encouraging us. Good night and good time ahead. Thank you.
Thank you for
Good
very
night,
good
everyone.
timekeeping, everyone.
Thank you so much.
Thank you, sir. Thank you.
So much, Doctor.
Good night.
Good night, sir.